Hi, this is Brian Wormers recording a lecture on care of patients with pituitary and adrenal gland problems for medical surgical nursing at the University of Sioux Falls. Some of the learning objectives for this is comparing hypo versus hyperpituitarism and the hormones and disorders that are involved with this. Compare the clinical manifestations of hypercortisolism and adrenal insufficiency. Prioritize nursing care for patient with Addison's versus acute adrenal insufficiency. Coordinate nursing care for the patient with Cushing's disease or syndrome. Teach patients how to avoid increasing intracranial pressure after pituitary surgery. Identify nursing interventions for patients with adrenalectomies. And then identify patient teaching for patients with adrenal disorders. So hypo or hyperpituitarism. So hypo is the deficiency of one or more of the anterior pituitary hormones. So this could be your adrenocorticoid hormone, luteinizing hormone, follicle stimulating hormone, growth hormone, or thyroid stimulating hormone. Hyper is, the opposite of that. So it's oversecretion, often of the growth hormone or prolactin or ACTH, and that can cause compression of brain tissue, neural symptoms. It can lead into acromegaly if this occurs after the growth plates have fused, or gigantism if it's before the growth plates have fused. So what do we do with this? So, trying to make a diagnosis, we're going to do ACTH stimulation tests. We'll look for those hormones for TSH, FSH, LH, prolactin, and growth hormone. We're going to do CT scans and MRIs, trying to figure out what's going on. Are there any masses or lesions or growths? And then, of course, we're going to restore that normal hormone balance as much as possible by replacing the hormones that are low or trying to bind the ones that are high. We can do a surgical management of this. Oftentimes you're going up through the nose into the back of the brain and then, removing this pituitary gland or the tumor that might be pushing on things. This is called transsphenoidal hypophysectomy. And then with that, they can do an endoscopic removal of any pituitary tumors or the pituitary gland itself. They can also do stereotactic radiosurgery, in which they are using high beams of energy and precisely multi-layering it, and so it gets mass radiation to one particular area while only providing minimal radiation to the tissue around it. So some of the nursing diagnoses that might be related to this would be fluid volume deficit, risk for falls because they get a little lightheaded, impaired mobility, hypoglycemia, hyponatremia, hyperkalemia, and osteoporosis. And of course, some of this can lead into seizures and other side effects like that. Diabetes insipidus, so many of these are related to increased intracranial pressure, and so you're going to see that in brain tumors, intracranial surgery, and head trauma are together leading the charge on these. But there are some that are idiopathic. We don't know why. So what goes on with this? It's a lack of antidiuretic hormone, and so within that they're excreting lots of urine and they're getting deficient on water within their body. Clinical manifestations: significant water loss, polyuria, polydipsia, and nocturia, so they're peeing all the time, but then they're thirsty with that, so they're drinking all the time. So diagnosis, so serum and urine electrolytes is a way to do this. Looking at serum and urine osmolality, trying to see the concentration of this. Looking at spectrogravity, trying to see how concentrate the urine is. And then you can do CTs and MRIs to see if anything's pushing on things, like tumors or ICP. Desmopressin is one of the main meds that we can give with this, or vasopressin. With this, it's you might be doing some IV stuff with this, but this can also be an inhaled formula. You're going to give it as ordered. You're going to provide adequate oral fluids with this, provide mouth care with this, and watch their daily weights, as you're trying to really watch their eyes and nose, and that would include how much urine that they're making. Adrenal gland hypofunction. So once again, hypo is too little. So insufficiency of adrenal corticosteroids. So you're not going to have enough cortisol, aldosterone, and this is going to lead to potassium, sodium, and water imbalances. So it might be called Addison's disease, or if it's severe enough and then it's a very acute setting, it might be an Addisonian crisis. And this is life-threatening, related to the hypovolemia that you're going to see with the water imbalance. So what do we see with this? Patients will say that they have a difficulty with their activity level. They're tired, they're weak. You can ask about the salt intake. Are they trying to intake more or less? Anorexia, nausea, vomiting, diarrhea, abdominal pain. They'll have weight loss. And then you can ask about any radiation that they might have had and how that's playing out in the adrenal glands. Objectively, so you might see an increase in pigmentation. And so that's this color right here. Some people say that they kind of turn a bronze color. You might see some muscle weakness and fatigue. They might have GI symptoms, hypoglycemia, hyperkalemia, hyponatremia, hence why they might be ingesting more salt, and hypovolemia. So diagnostics, yeah, we're looking at the serum for cortisol, glucose, potassium, ACTH. We might do an ACTH stim test to see how they do with this, if they improve or if they worsen. And then we might do skull x-rays, pretty rare, but more commonly CT or MRI to look for anything pushing on the brain. With this, for nursing priorities, fluid volume deficit is huge with this because of the urine output that they're doing, and they're hypovolemic. So they're also at altered risk for tissue perfusion due to that hypovolemia, fatigue, risk for electrolyte imbalance, and all those things that we mentioned on the other page, with hyperkalemia, hyponatremia, hypovolemia, etc., etc. Planning and implementation, so promote fluid balance, monitor fluid deficit, and prevent hypoglycemia. So what do we do? Weights, I's and O's, pretty standard stuff. Monitor vital signs and weights. Look at the cardiac rhythm to see if those electrolyte shifts have changed that at all. Monitor those lab values. Replace any missing hormones and replace any of the electrolytes that they might need. Replace some of the steroids, so the hydrocortisone or the mineral corticosteroid. Now if they've got too much and it's hyperfunctioning, so you might see that they have Cushing's disease, so that's a high cortisol level. And so this can be pituitary or adrenal. It could be caused from cancer or some tissues not acting correctly with this one. Unfortunately, this affects all body systems as it is metabolic, but common signs and symptoms would include that buffalo hump, moon face, and striae. So that's kind of like the stretch marks type of situation. So decreased lymphocytes, suppressed immunity, and then decreased muscle and bone mass, and both of those can put a person at risk for falls and fractures. Subjective, so what's their health history like? Any drugs that they have been on before? Anything that would block this or cause this? Maybe they're on steroids. Maybe they've had multiple bursts of steroids. Have they had a weight gain or increased appetite with this? Any muscle weakness or fractures? Frequent infections or easy bruising? Those are all signs of having too much of your steroids. So with that, you're going to see changes in fat distribution. You're going to see muscle wasting and weakness, skin changes, such as the striae and the thinning of the skin. You're going to have hypertension, sodium, and water retention. You'll have some high glucose, and you'll have some decreased lymphocytes, putting them at risk for infection. And so with this, you can kind of see the obesity. You can see some of these changes, moon face, buffalo hump. So all those different types of situations that can go along with this, including purpura and skin ulcers. Diagnostics, we're looking at ACTH levels, trying to figure out if this is pituitary or adrenal in nature. We're going to do salivary cortisol levels, looking for what that level is. Dexamethasone suppression testing, we'll do x-rays, CTs, and MRIs. Nursing priorities of this: fluid overload, risk for injury and potential infection. So what's our plan and implementation with this one? So acceptable fluid balance, we're watching for I's and O's, watching for pulmonary edema or heart failure related to this. Drug therapy, so either enhance or inhibit the ACTH depending on which way that they're following with this. Monitor weights and I's and O's. Watch for ECG changes due to the electrolyte shifts and imbalances, and then restrict fluid and sodium as needed. Collaborative, so radiation, so if there is an adenoma or some kind of tissue there that's growing that shouldn't be, maybe we could use radiation to knock it out and destroy some of that. Surgical, we can talk about all those things again, but the hypophysectomy and the adrenalectomy to remove tissue at either of these locations to try and decrease that hormone. So here's that hypophysectomy again. So basically let them know that they're going to have some signs and symptoms after this and some changes. And so changes in hormone levels is normal because we are removing this. And so they might have some changes in sexual functioning, body changes. And unfortunately, when you remove that, even if you're supplementing it, it can be a longer course of things. Be very careful with this. So remember, they're going up the nasal and into the brain, and so you got to have that packing in there 2 to 3 days, and you want to make sure that you're not increasing intracranial pressure. So by coughing, sneezing, blowing nose, things like that. They don't want you to brush teeth because you could poke at that incision site that they go through, and if that's the case, then that can be a site for infection. So operatively, they really try to do as minimally invasive as possible. You might take a muscle graft from the thigh to make a patch afterwards, and then of course that nasal packing after it's closed, just to try and get it to heal well. So post-operatively, so we're monitoring for any changes, neuros, vision, level of consciousness, strength of extremities, all those kind of neural checks. We'll look for any kind of transient DI, because we did talk about DI, and any kind of surgery or increased intracranial pressure can cause that. So if you get a head bleed or something like that, that might cause enough pressure to throw them into a DI. If they have postnasal drip or increased swallowing thing, that might be signs that you've got leakage of ICP fluid through the back of their throats. And so with that, that could be a nasty site for meningitis or other things like that if we get bacteria into their cerebrospinal fluid. So avoid coughing, like we kind of set up there. Monitor them for infection, including meningitis. So if they've got signs and symptoms of a meningitis, which can happen after this, you need to take that very seriously. Avoid bending, prevent constipation. You're trying to avoid having increased abdominal pressure, intracranial pressure, and doing those kind of things. Adrenal hyperfunction, you're going to probably take out the adrenals. This could be unilateral or bilateral depending on what's functioning, what's not. So preoperatively, you're going to get a good baseline for electrolytes, glucose, EKGs, look for any infections, try and prevent those, prevent fractures, and then before they even have surgery, they're going to get a dose of glucocorticoid steroids to try and mitigate the amount that they will drop after the surgery because they will drop related to the removal of the adrenals. Postoperatively, so assess for shock. It's a very real thing since we're taking out the adrenals. And so then afterwards, they're going to probably require lifelong steroids and mineralocorticoids replacements. So our goal is that they remain free from injury. So we're going to monitor them closely, both their skin and any signs and symptoms that they could have breakdown. We're going to watch for any fractures related to demineralization of the body. We're going to look for, trying to protect that GI mucosa because sometimes this can be very stressful and that can increase your H2 production and lead into gastric ulcers. Prevent infections, we talked about these kind of things. We do want to watch out for muscle weakness and fatigue, monitor their weight at home, and like I said, hormone replacement therapy is probably a lifelong thing for these patients. So since they are going to be on these lifelong hormone replacements, we do have to protect them from infection. So all these things are ways to help your patient avoid getting sick. On the last slide here, we've got pheochromocytoma. So basically, this is a tumor on the adrenals, and so it's catecholamine secretion. So one thing that I want to emphasize is that if your patient has this, do not try to feel it. It's very tempting. It's like, oh, I want to feel the mass that's in their belly, and you can do it. But the bad thing about this is when it says catecholamine secreting factors, number one, you could break part of that off, then you get metastasis, and that's going to increase their level of care that they're going to need afterwards. Number two, if this is catecholamine secreting, you can secrete those catecholamines and shoot their blood pressure sky high. So increased heart rate, increased blood pressure, increased risk for stroke, heart attack, and bad cardiovascular things. So do not palpate this if your patient's been diagnosed with this. So how's it going to present? Tachycardia, hypertension, headaches, palpitations, hyperhidrosis, so increased sweating, hypermetabolism, so that they're all ramped up and they're ready to go. Diagnosis, clinical presentation, some of the labs, so we can kind of look at that, and then imaging, usually CT with this one. Medications, watch that hypertension and treat that appropriately, and trying to relax that body. Surgical management of this is through removal of that adrenal. They usually do pretty well after this, and usually the pheochromocytomas are unilateral in nature, and so that being said, usually the one on the other side is working correctly then. Alright, that concludes this lecture. If you have any questions, feel free to contact me.